All right, so to start this afternoon session, we'll have fracture care for the primary care provider by Dr. Jason Jagodzinski. So Dr. Jagodzinski is an orthopedic surgeon here at UCSF. He did his orthopedic surgery residency at Loyola University Hospitals. He did his fellowship in pediatric orthopedics at Children's Healthcare of Atlanta. He has special interest in pediatric orthopedic trauma, caring for patients with neuromuscular conditions, and osteogenesis imperfecta. He's also one of our UCSF clinical informaticists as the physician lead for the pediatric surgical services. Welcome, Dr. Jagodzinski.
All right. Well, thank you very much, Dr. Borja, and wonderful conference so far. I had to commend her. I feel like I've seen more people from farther distances than I have in years past here, including somebody from Wisconsin, where I'm from. So today, I kind of chatted with a couple of you earlier. This has been a talk that's been given a few different times, but it's always amazing how little orthopedics, primary care residencies and education get. And so I really wanted to make sure that, we kind of take a step back, figure out some of the basics, and work through kind of what you're able to take care of, because a lot of these things are fairly straightforward. No disclosures, and don't have any unapproved or investigative uses for this, because plaster is a pretty old thing. So we don't really have to innovate too much for fracture care. So some objectives, want to talk through and go through some of the unique features of pediatric fractures, talk about some of the common fractures, as well as understand what you can do and what you need to get rid of from a primary care office. So first off, how common are these? So I'm going to have people stand up if you've seen a fracture in the last 6 months of your practice. All right. How about if you can sit down if you have seen a fracture in the last, or if you have seen a fracture in the last week, stay standing. All right. So you can see this isn't a foreign concept. You all can sit down now. Thank you. So this is not a foreign concept. I mean, this is something that happens regularly. 20% of children seen for an injury will have a fracture. And it's about 1.2 million pediatric fractures per year in the US. That's 1 per 100 children years, and about a third of all kids before they hit 17 will have had a fracture. This is pediatrics, right? Like, you will see this. So definitely have to have a basic understanding. So within fractures, this is a long category of fractures. And I will tell you, if you focus on just the top 3 diagnoses, you're going to see pretty much all of the fractures that you see on a regular basis. So distal forearm, clavicle, and fingers. When we break down the numbers within UCSF, out of 2023, there were 11,753 visits for just fracture care. When you break down per quarter, starting in quarter 1, so January to March, rising up, there is a seasonality to fractures. The blue bar at the top is pelvis fractures, the green bar is lower extremity fractures, and the pink is, the orange is upper extremity fractures. You can kind of see the breakdown. Pelvis fractures don't happen very often. They can. We're at a level 1 trauma center, so high energy mechanisms, you may see some. But you're going to really get the upper limb and the lower limb fractures. So that's where we're going to focus in on here today. So some general principles. Looking at x-rays, I want you to be able to at least see something, recognize, hey, there's a broken bone. We have some discussion points later about some radiology topics, but we can go through some just very general principles. So first off, you all know this, they're not small adults. There's unique features to kids. They, for being not small adults, have wonderful remodeling potential. So it doesn't have to be perfect when you leave that fracture. It doesn't have to be perfect. We can live with some imperfection in this, and selling that to your families is one of the harder parts. Majority of pediatric fractures, non-operative. So when we talk about, does this need an orthopedic surgeon? There's a lot of stuff that can be taken care of and managed in a non-operative setting, and many things can also be taken care of by you. Immobilization is the key though. So how do we immobilize, where, when, what is enough immobilization, what needs more immobilization, and finally, what are some of the pitfalls and the potential disasters? At what point is this going to fail? And how do you avoid you taking care of something that goes on to failure and make sure that they're not getting lesser care? So the final thing that I have in here is that most families, even though this is super common, I mean, we see, as you saw, a lot of fractures. This is a huge event for many people in their lives. You know, the kid broke their bone, like, oh, the summer of 2020 is the kid, you know, the short leg cast summer for this kid. This is a big event. So how we approach it and how we manage this is really going to be pivotal in how the family makes it through this difficult event in their life. So some general principles, fairly wordy slide, but I wanted to go through, talk to them. How did it happen? Was it seen? How high of a height would the monkey bar fall? How fast was the bike going? Is it a ground level fall? How long ago did it happen? Was it 2 days ago? Was it 2 minutes ago? There's a problem-focused history. Physical examination is key on these. I have really not found a fracture that doesn't hurt. Maybe if they don't have sensation, so spinal cord injury patients or other patients, no kid is going to bear and fight through without a little bit of a give on their poker face. So if you push on a fracture, it should hurt. If you push on something that could be broken and it doesn't hurt, odds are it probably isn't actually a fracture, or at least not something that you need to be as worried about. For fractures hurt. If they are tender and they guard, that's a concerning sign that there is something real. Deformities, obviously if the arm is crooked, that's a different scenario than the arm looks like an arm, but maybe there's a little bit of swelling, maybe there's some bruising, abrasions, or any time that you see open wounds, we need to be thinking about, where is that? How did that happen? Was that 2 days ago, when they skinned their knee and now, completely separate of the actual injury to the ankle? So all things that you have to just be aware of and think about. And then must document your neurovascular status. So distal to the injury, and as best you can, try to get a neurological examination. I really find distraction great, or sitting and watching them play with something when they don't know that you're watching them, right? So as pediatricians, you're not always going to get them to follow your lead, but you can sit there across the room and watch that they're playing perfectly fine with the parent's cell phone, but the second that you start to talk to them, they freak out. But all the meanwhile, you can see, were they moving their digits? Neurological examination, I do rock, paper, scissors. It's a great way to kind of quickly recognize the three main nerves moving into the forearm. So you've got your thumbs up. Anybody know what that is? What nerve? Radial, I think I was our PA corner in the back. Good job. So if they can do a thumbs up, specifically looking at the IP joint of the thumb extending, that is intact radial nerve. If they can do an okay, and I tell people not a teardrop, all right, so it's not crying, sad, okay, it's a circle, because you need to bend at the IP joints of the index finger. That's the median nerve function. And crossing your fingers, so if they can do this, that's good, but if they can cross, that's clearly your ulnar nerve is intact, all right? So thumbs up, okay, and crossing your fingers. And I love when kids come back to clinic on their final visits and they just do this. They're like, hey, I'm fine, all right? They've learned their own neurological examination. All right, so now that we've gone through sort of some very basics as you're sitting there learning about the kid's injuries, we go into they're not small adults. The main reason why pediatric fractures are different is there's a physis. So the growth plate is really the major difference between adult and pediatric fracture care. You are looking at a classification system here that you've probably all heard of, But really, I think this is the main thing to understand from a pediatric fracture talk is the Salter-Harris classification and some of the where does this go, where is this a problem, and if you can understand the ends of the bone and fractures around the physis, you're going to have a good understanding. So I wanted to take a moment to kind of go through this because you probably didn't get enough of this in your training, or maybe you are far enough out of training that you don't recall. So Salter-Harris 1. Salter-Harris 1 fractures, I have a way of thinking about things. Salter-Harris 1 looks like a number 1, all right? So this is all the way across the growth plate. There's not an associated bony edge on either the metaphysis or the epiphysis, all right? So Salter-Harris 1 looks like a number 1. Salter-Harris 2, we have a little bit of a different fracture line. You can see here that you have a gap through part of your physis, so the growth plate is disrupted, but there's a little piece of metaphysis, so the bone is stuck. So you turn it on its side, kind of looks like a 2. All right, kind of. All right, so nice. Sometimes it's the right, sometimes it's the left, so therefore this one worked. All right, so Salter-Harris 3. Now we're starting to get into a little bit more of an involvement of the growth plate. You can see here that your growth plate has an injury along the physis, and then it exits through the epiphysis. Down here is going to be something else. All right, so this is now into a joint space. So Salter-Harris 3 fractures are a little bit more involved. Displacement at a joint surface is different than displacement in a metaphysis, all right? So I'm starting to already think there's a little bit more of an involvement here, something that I'm gonna have to worry about from a long-term fracture healing standpoint. So now you're like, how's he gonna do this? All right, see, it kind of works. So Salter-Harris 3 goes across the joint space, all right? So now Salter-Harris 4. This looks worse already. I'm hoping that you're all sitting there like, all right, you're like, all right, it goes across both metaphysis. The growth plate actually isn't really disrupted, but the joint space is really, really off. So here we start to worry about bony bridges, right? So when this heals, there could be a bridge across here that doesn't heal as well, but you also have the disruption of the joint surface. So again, a little bit more of a concern. Spin it around, looks like a 4. All right, so Salter-Harris 4, a little bit more involved, and now you're seeing that there's some problems with the growth plate and with the joint surface. All right, so Salter-Harris 5. This is a harder one, and I think this is one that people sometimes struggle with. This is a good one to sometimes get the contralateral side, so getting an x-ray of the other side. One of the nice things in most of orthopedics is we have 2 of the injury. You have something to counter examine. So here you have compression of the growth plate on the one side, and the growth plate is either normal or distracted potentially on the opposite side. So this, it's not perfect. But a Roman numeral does work on this one. So again, this is more of a concern, and Dr. Kamen and I were speaking earlier that a lot of these we don't even recognize until later. And this is sort of the snake in the weeds type of a thing, where eventually it might come and get you, and longer term deformity may be an issue. All right, so now we understand a little bit more of the physis. So then we can start thinking about management. The mainstay of most pediatric fractures is, again, non-operative means. So you're probably going to be using some form of immobilization. You can see a fiberglass cast in this situation here. And so, we need to understand how are we going to manage these fractures. So first off, you got to have your plan for your fractures. If you're going to be taking care of some kind of fractures in your clinic, you need to have some basic setup, be it braces, like a forearm brace, a sling. Maybe you'll feel comfortable with like some orthoglass splinting material or otherwise. But you need to understand, all right, kid shows up with something, some form of immobilization is going to be key. Whether it's having a full stock DME cabinet of the stuff that you saw at the Donjoy out here with boots and everything, or if it's more scaled back to just having some very basic splinting materials. Understand what your clinic can do and also what it can't do. So having some form of immobilization plan is important. And you also really need to understand what's an emergency. At what point is this kid sitting across either in an urgent care, an emergency room, on the field if you're covering sporting events? What point do I need to get this kid fast to somewhere else? And so we'll talk a little bit more about that shortly, but things like an open fracture, if there's a pulseless limb, these are things that you need to understand that isn't a splinted, come back, we'll send the referral in the next few days, you'll be able to be seen. So understanding that. And then really understanding the common fractures. So we just went through the Salter-Harris classification. These are going to be things you'll see. And again, look at the x-rays occasion. I mean, we just went through a pretty quick, simple, basic thing, but you can use your gestalt and recognize, some of these like, oh, that's really displaced, or that's pretty minimally displaced, have a better understanding of what's going to do that. But also recognize that after your clinic, some of the things that we consider in an orthopedic practice for pediatric fracture care is joint displacement. Is this kid going to have arthritis in the long run because of this injury? Are they going to have a higher risk of growth disturbance because of a Salter-Harris 4 that I need to be aware of and watch, or a Salter-Harris 5? So those are some of the things that I think if you're planning to take care of fractures, pause and think about, like, how do I approach this and how do I take care of that? So for the basics, again, in the clinic or in urgent care, neurovascular examination, thumbs up, okay, cross your fingers, cap refill, pulses, moving toes, sort of up and down of the ankle. We need to have a better understanding of, is there neurovascular compromise? That becomes one of those emergency situations. Then you need to have some form of immobilization. So, the picture here has multiple different splints that could be applied. Usually we think about sort of this sugar tongue. Dr. Borja, I forget, is there a splinting clinic? I know in years past there's been some. Okay. So quite often when you look at immobilization, you want to have some form of immobilization that, one, immobilizes the broken piece, but also the part of the joint above and the joint below. Because if you can move those, you're also going to be moving through the fracture, all right? So you have to have that sort of, if the break is in the wrist, you need to immobilize from the forearm to above the injury. If it's at the humerus, it's kind of hard to do. There are these splints that can go up and under the arm, and then a sling and a swath. But you have to think about, all right, how can I relatively give this person some comfort? Because immobilization, one, helps to reduce the swelling of a fracture. It also decreases the movement of the bones against the other bone, and that's really the pain generator. So anything you can do to sort of calm that fracture down in the transport, in the long-term management, that is going to be the benefit that you're shooting for with immobilization. And then you really have to evaluate the urgency. So if there's an open wound, the risk for infection is higher. If there's a nerve or blood vessel injury, we need to get them moving. If there's really a large displacement, you need to get them going and figure out, how are you going to mobilize them? Is this something that, like, you need an ambulance now, or you can get relative immobilization and get to an urgent care or to the orthopedic office later? But think about sort of in your basic fracture approach, how am I going to get this kid to the next step? So a little bit more about the emergencies. Open fractures are a common a communication of the outside world to the fracture, whether that be through poking through the skin and the bone impaling dirt on a soccer field, or if it is the breaking and tension failure of the skin and the skin flora is on the fracture callus inside. These are things that we try to avoid. So one, we need to know the tetanus status. So making sure that they are up to date on their tetanus, getting antibiotics started within as soon as possible. Our goal is typically within an hour of them reaching the hospital. 6 hours, is sort of the target as well. But if it's an open fracture, that's not just a splint and see them tomorrow type of a thing. Neurovascular compromise is the other thing. A white pulseless hand from a supracondylar elbow fracture is one of the things that gets me going in the middle of the night out of my bed. My kids now even know if the fracture is open or there's no pulse. All right, daddy's leaving right now. So those are things that you really have to have a good understanding for. Severe displacement, and especially if it looks like something is tenting a skin. So like in a clavicle fracture and it looks like there's a lot of displacement, the skin is starting to blanch. Those are things that maybe right now it's not open, but if we don't address it, it could become open. So those are some things that we need to watch for and manage. And then compartment syndrome, we'll talk a little bit more, but that's really sort of in the next 4 to 6 hours, 72 hours, what are things that people need to be watching for. Severe pain is really that marker for me that says if there's pain and the kid is not able to be comfortable, we really need to be mindful. So management, immobilize, are they comfortable and not emergent? Call and get either to a referral soon or follow up for your fracture care in your own office. And if they're not comfortable, if they're not, if they are emergent, then we got to get them moving quickly. So these are kids that you should be getting going. And splints don't have to be fancy, right? A box, a towel, and some tape. There's probably that on pretty much every sporting event field. There's probably that somewhere around in your clinic. We can find something to provide some stability for an injury in the very short term. All right. So now they've actually made it to a care center so that you can get some x-rays. And so there's some important things. Orthogonal views. We have a saying that one view is no view. All right, you need to get 2 different views to really fully understand, because it's a 3-dimensional structure and a single plane image is provided. So you need to see the 2 different views. Usually we see AP and lateral for long bones. You may add a 3rd view for joints, but AP and lateral at minimum. Make sure you can see the entire bone and also look above and below. The periphery of the image is where the problems lurk. So does anybody see anything of concern? Okay, it's kind of broken. How many bones are broken? I see 1. You guys can speak too, like I talk a lot right now. How many bones do you see broken?
1.
I see 1. Okay, somebody put 2 as a number, and I'm curious, what do we see that's also wrong? Maybe it's not a bone that's broken, but is there another thing that's wrong? I hear rumblings. You're close. Joint. I love it. All right, so this is called a Montesia fracture. All right, so the ulna is broken, but the radial capitellar joint is dislocated. So peripheries of images always glance around, all right? And you may find something like this, and actually the bigger concern on this is that radiocapitellar joint dislocation. It's not the ulna. The ulna we'll be able to fix that. That's pretty easy. The bigger concern is if this radiocapitellar joint doesn't get reduced, that's a big problem. All right? So these are things that I don't want you to be afraid to take care of things, but I want you to feel comfortable to look at and have a little bit of a semblance of this is why I'm looking at it and where I'm going to look and how I'm going to assess things. So now that we've had a walk through some of the background of pediatric fracture care, we're going to get into a few specific case presentations, trying to mimic some of the things that you'll actually see in a pediatric practice out in your community. So 6-year-old, wrist pain, they fell from their bicycle, a little bit of swelling, and we have some x-rays, and you've done more than just look at the report. You take a quick look at the x-ray, and you will see something. What is that? Buckle. Yes, good. All right, so a buckle fracture. A buckle fracture is a unique fracture pattern to kids. The bone still has a little plasticity, and so it bends a little more than just breaking. Our adult bones are more brittle, and so you wouldn't see this fracture pattern in an adult. So you get compression on one side, and the bone bends and kind of buckles on that side, but the opposite side is intact. So when you look at the arrows, you can see that this side, not a nice smooth straight. This side, maybe there's a little bit of a wave, but there is not a fracture across. So this is a one side of the bone, and it is stable. Okay, so this is very common in the distal radius, like we talked about before, some of the epidemiology, the numbers of the fracture, you see far more in the upper extremity. The distal radius is the most common non-finger fracture. And almost all of the, or nearly half of the pediatric distal radius fractures is this variety. So they are very, very common. These may not show up right away as well, so it's something to talk about. I mean, this might be the kid, fell, was kind of unhappy. We put a little ice on it. They went to sleep. They're still hurting the next day, type of a thing, and they may come into your clinic, in a delayed fashion. That's okay. I've probably done that with my own children before and haven't even thought about it. This is where I was talking about. If you push on that spot of the bone, so if you all feel you've got your thumb. There's a little valley, and then you have a bone. That's your radius, okay? You bend your wrist up and down, and it's not moving, that's radius. If it's moving, that's probably scaphoid. If you feel tenderness there, that's bad, all right? Give us a call on that one. That could be a scaphoid fracture. Buccal fractures happen farther below, all right? So it's below the epiphysis, in the metaphysis. That's where you're gonna get a buccal fracture. If you push a kid right there, they hurt, they have tenderness right there, and you see an x-ray that looks like this, you guys are more than capable of taking care of this. All right, so these are easy to diagnose. Look at the x-ray to understand. And with these, again, the AP and the lateral radiographs, all you need, you don't have to get any other special views. You'll see bulging of the cortex on one side, intact on the other side, right? This is a stable injury, get some form of immobilization. These don't displace if they are buccal fractures. And usually it's a splinter cast for about 2 to 3 weeks. And studies have shown that a removable brace from your closet in your office or cast or splint are equivalent, even if the kid takes them off. Right? So if the kid takes them off and takes a big fall, yeah, it's possible they could get re-injured. But the reality is, I say kids are kind of like a dog with a hurt paw. They're probably not going to do things because they don't have that secondary gain. They're hurt, they're probably not going to go out right away. So if they wear their brace most of the time, I say when they're outside of the house, they will be fine. And the other thing is there's actually data to support that treatment in PCP's office is absolutely appropriate. There's no need for reduction. Put the brace or the cast on, remove the brace once they're asymptomatic, and generally after about 4 weeks, they're able to return to regular activities, and usually don't even need x-rays. So the study to support it showed that also patients really just required one follow-up. Most of the kids only used the splint for about 3 weeks, and there was very high satisfaction with this, both for the patient and the family. So go ahead, take care of those, but know which ones are bad, all right? So when we look at this, and I actually took this from one of the patients that I saw when they looked like the picture on the left. So the picture on the right is where they presented, and it was called a buccal fracture. All right, great. I love it. You guys are recognizing that's not a buccal fracture. There is a fracture line on both sides of the cortex. This is not as stable. This is not a compression on one side. It has the potential to fall, and left immobilized could look like the picture on the left. Still gonna probably be fine, but this is not one to just slap a brace on and say goodbye. This is something that is probably more appropriate for a pediatric orthopedic office that can immobilize more with casts and be more structured and follow up on it. But look at the x-rays, all right? And I think that's the important thing. I will even tell you that the radiology read on this, not ours, because our pediatric orthopedic radiologists are really good, but this comes from an outside facility. Take a quick look at the x-rays if you can take a look at them. And if you see that fracture line on the opposite side, it's not a buccal fracture. Don't believe that. Get more advanced care. Non-buccal fractures also don't fall into these pictures. All right, so when you see wrist fractures that are severely deformed, that have open wounds, if there's something called a green stick fracture, which is also sometimes thrown around in reports, green stick is a bent bone fracture. All right, so there is actually more displacement to it. Those have the potential for longer term follow-up needs and may also sometimes need reductions to get out of that bent position. Displaced fractures and physeal fractures are also things to really be mindful and watch. So you absolutely can take care of many of these buccal fractures, but again, be aware of some of the things that might come up and bite you later. All right, to another common thing. So a 4-year-old has a fall onto their right shoulder, comes in, has a little bit of discomfort. They're still in pain, need a little bit of Tylenol last night, but they're using their arm. Everything seems to be pretty normal. So what do people see? Undisplaced fracture of the clavicle, mid-shaft, maybe a little bit of angulation when we compare it to the other side, but not really. At 4, they got a lot of growth remaining. Clavicle fractures heal almost uniformly, and they're fairly common. So 4% of all pediatric fractures are clavicle fractures, middle third. So when you break the clavicle into thirds, the middle section is by far the most common. And it's usually a fall directly onto the clavicle. It doesn't usually displace very much if they're really young, and it's because the periosteum, or kind of the skin around the bone, really is thick and holds onto these quite well. So what do we see on physical exam? Kids will guard, you push on it, they'll hurt. All right, so again, fractures hurt. There will be potentially some deformity. There may not be even. There may be some bruising, potentially a little crepitus, so crunchy if they're moving, and then plus or minus some bruising. Again, must assess some form of neurovascular status. So thumbs up, okay, crossing your fingers, radial, median, and ulnar nerves. Once again, open fractures, albeit very rare, is one of the only true indications for surgical management on the clavicle and neurovascular injury. And even those, not always do they need surgical management. So finally, this is where you all have the advantage for the most part. I don't even know where my stethoscope is anymore, so I can't listen to a lungs. There's a very rare potential for pneumothorax, so maybe you could actually diagnose that for us. Thank you. So, radiographs, while you get the x-rays, sometimes bilateral can be really helpful. All right, so you can compare side to side. It can also help to understand the relative length. So one of the indications for surgery can be excessive shortening. And so it's very debatable in the pediatric literature. So I'm not going to get into indications, but seeing some relative length of the clavicle is helpful. Having them be upright, either if it's sitting or standing, can also be helpful because the weight of the arm is how that fracture will deform over time. So if you can see what it looks like today with them in an upright position, that helps to understand, is this more displaced or is it less displaced? And so things to watch for. And then this is how I would diagnose the pneumothorax. I would look at the lung markings. Actually, I would ask Dr. Kamen to look at the lung markings personally. So AP and axial views, all right? So we can diagnose x-rays with or clavicle fractures with one x-ray commonly, but there is actually a second view that we get, and it's an axial view to be able to help differentiate a more displaced fracture. And so that's not the displaced fracture. These are the two same fractures here, but you can see how you're looking at a little bit different view. You can see how there's now a prominence underneath of the clavicle. So you can see how angulated it is in a second view. Look at your x-rays. All right, there's some common themes that I throw out here. And again, don't be afraid. Take a look at your x-rays. These are things that if you look at a few of them, you'll get a better understanding. And when you see them in combination with what we've talked about, I think you'll be far more comfortable. And you can understand what the radiologists are saying. So, Clavicle fractures, typically middle third fractures, less than 100% displacement, meaning they're not completely shifted or shortened, can be treated very well by PCP offices. Slings, equally efficacious to figure of eight braces. In fact, I'll tell you the last figure of eight brace I saw was when I had one as like a 10-year-old. All right, slings work really, really well, and they're so much easier and better managed. Follow-up x-rays at around 4 weeks, usually you're gonna have some evidence of healing, some callus forming at that time, and you'll probably DC that sling at that time and begin some range of motion. These are 2 exercises for the physical therapists in the room. It's far less than what you would involve, but just simple pendulums. So the farther forward you lean, the farther abducted and forward flex your arm is, so you can get a lot of range of motion without having to lift the arm above the head. And then simple wall climbs are some really good exercises that usually I'll start at about the month. And then they can resume their full activity when strength and their range of motion returns to baseline. So that's usually anywhere from like 6 to 12 weeks for most people. And actually quite often, the kids will come back without their sling, and they're going to be feeling pretty comfortable. So they'll usually get rid of their sling before radiographic healing is actually seen. We sometimes need to see these though. So I think there are some injury patterns that are more concerning, and I have 2 different categories here. So when to refer towards an emergency room, that's something open, right? So there's bleeding on the outside of the skin, neurovascular injury, or pneumothorax or some sort of a chest wall injury as well. The orthopedic clinic, if it's displaced but the skin's intact, they're neurovascularly intact, then they can come into clinic in the next couple of days, give them a sling for some comfort. Usually we are probably more commonly being asked to follow medial or lateral clavicle fractures because there can be some potential issues with displacement. It's more concerning there, as well as long-term function in the shoulder, and segmental or Z fragments. So when you see this sort of extra piece and really displaced, those are some that sometimes we will fix surgically. And if you do see these and they continue to have pain, they're not healing at 4 weeks on an x-ray, 1, check a vitamin D. 2, they're probably somebody that maybe we should see. Those delayed healings, they may wind up with more of a chronic abnormality. So something to come on in a little sooner. And the other thing I would recommend if you're talking to anybody who is treating a child with a clavicle fracture is the more upright they can be sleeping, the better. All right, so for some reason, your arm down at your side hurts much less than your arm falling backwards with a clavicle fracture. So the more upright, either in like a reclining chair or otherwise, is really helpful. So the other thing that I think that you need to talk to family members, and again, we don't think as much about clavicle fracture because, hey, it happens, you get better. But the family, again, this is one of the biggest injuries or issues in their lives. So their little 4-year-old kid in this situation now has a break. So day of injury, maybe there's some swelling, there's some tenderness, and about 4 weeks later, there's this mass. You need to tell them about the bump. All right, it's a subcutaneous bone. There will be a lot of callus that forms, and they're going to come in and they may worry about this huge tumor that's growing there. That's just normal bone, and it will remodel in time. So there is your clavicle fracture discussion. We have some 3-year-old with a child. 2 minutes. Oh, I thought I had 50 minutes. Are you serious? Darn it. All right, so 7 minutes. Okay. So 3-year-old with a child, refusal to bear weight, and after getting leg caught on a slide. So we've got our x-rays here, and it's okay from your vantage point to say they look pretty normal, because they kind of do, unless you really, really look close. Same picture blown up even more, and even more arrows to point this out. So this is what's called a toddler's fracture. It's a non-displaced oblique spiral fracture of the distal tibia. And it is quite often happening with that sort of slide mechanism or slipping and a rotational story. And it's always going to have the fibula intact. And it's typically in walking toddlers less than 4 years old. And this is a stable injury. So like we talked about with a buckle fracture, this is not going to move. You can take care of these. And it's usually a kind of a low energy twisting mechanism and the kid stops walking. But we need to think about what are some of the worrisome sides. So if they're not walking yet and they come in with a toddler fracture or something else, you need to think about non-accidental trauma. All right, so this is an unfortunate problem, and anybody who takes care of pediatric fractures this is one of the differential diagnoses. And so if they're not walking and they have a twisting mechanism injury, your red flags should be raised on that one. If there is involvement of the top or the bottom tibia, so the proximal or the distal tibial metaphysis, maybe we are worried about growth disturbance. So you need to worry about that. That might be something to send over towards orthopedic office. And then if there's tibia and fibula fracture, there's less stability and it's going to need casting and closer monitoring than just a simple toddler fracture. So physical exam, they're going to limp or not walk at all. They're going to hurt where the fracture is. So you may see an x-ray that doesn't look bad, but they are point tender on the bone. It's a little bit concerning. They're not going to have gross deformity. They may not have bad swelling, maybe just a little bit of local, but again, take a look at their neurovascular status. And x-rays, you're going to want to see AP and lateral, the fibula, look at it. If there's a break there, this is like the opposite cortex in a buckle fracture. And so you need to see that. And they may not even have a visible fracture line at that first one. If you come back in a couple of weeks and get an x-ray, you may actually see some resorption at that fracture line if it's true fracture, or some early callus and periosteal reaction. So treat it with some sort of immobilization. They can walk out it as they feel comfortable. They won't until they feel comfortable. So let the child sort of take the lead on that. And then follow-up x-rays are not usually necessary. Similar to the buckle fracture, there's great evidence to support that this is a PCP capable fracture pattern. So almost all of them were fully weight bearing by 4 weeks. There was no difference between a short leg cast or a cam boot. So if you have a couple of cam boots in your clinic office closet, this is something that you can, even if in that first, like, hey, they really hurt, but the x-ray wasn't bad, get them into a boot for a little bit. And if they feel comfortable running around later, they won't need it beyond that first week or two. That's fine. And then follow-up radiographs didn't change how we manage these. So I'm going to skip by this one to get to what are the problems. So what's not a toddler's fracture? Any tibia fracture that doesn't fit what we just talked about. All right, so if you see comminution like this, so if there is multiple fracture lines, you can see a segment missing, that's not a toddler fracture. If there's a fibula fracture, so if you look at the long skinny fibula here and you don't see a fracture there, there's minimal fracture there, it could be a toddler's fracture. If you see a fracture in the fibula, it's no longer stable enough, it needs a little bit more advanced casting. Open fracture, any concern for compartment syndrome. So compartment syndrome, looking at it, you've heard of the 5 Ps, all right? In pediatrics, I think we should have a 6th P. All right, so you have pain out of proportion, pallor, so white, paresthesias, pulselessness, paralysis, but honestly, these are all poor criterias. All right, so we don't go to those 5 Ps. Those are more consistent in adult compartment syndrome. So we think about the 3 As, all right? Increasing analgesia. They're in pain, they're in more pain, they're not able to keep up with their pain. That is a concern for compartment syndrome. Anxiety, a lot of kids are anxious, but these are the kids that, like, you walk in the room and they are never calm. Like, there wasn't a moment where you watch them sitting on their parents' phone. Like, these kids are just, their anxiety is through the roof. You come close to them and they're freaking out. And then agitation as well. Like, these are the kids that they can't sit still. Like, there's something wrong. These are concerns. And the cycle is the problem. So this is a muscle injury, or, the bony injury that creates increased pressure in a closed space that further limits blood flow, that leads to more muscle problems, which increases the pressure more, leads to more problems. And it's urgent because if we don't do anything, 4 to 6 hours later, irreversible muscle damage can occur. These are the kids that you're going to have your spidey sense, right? You're all aware of a clinical management of patients. I've got like 2 slides left here. Open fractures, we talked about. Don't let a deep abrasion, a pinpoint puncture is not that, right? So if you see blood or anything around a deformity or a fracture, think this could be open. punt it to an emergency room, urgent care, somewhere to get a better understanding. Specifically, if you see slow, steady oozing bleeding or fat droplets in the blood. So the bone is a very vascular structure, and especially metaphyseal bone has fat. So you'll see little droplets of fat like oil in water. And then all open fractures require treatment. So get them to us, we can get them on antibiotics and tetanus. You can take care of fractures, all right? You're more than capable of that. Know what needs to come to us and identify your potential disasters, all right? And that's my kid. Some of her pictures were in there. So, questions as much as Dr. DeBorgia will allow.
Actually, in the interest of time, we'll do back-to-back lectures, and then we'll save all questions at the end.